Hello, my name is Joane Titus. I'll be presenting a case report on skull metastasis from hepatocellular carcinoma following liver transplant and hepatocellular microwave ablation. Hepatocellular carcinoma is the most common primary liver malignancy and often impacts those with underlying chronic liver disease. Those who have risk factors such as cirrhosis have up to a 3 to 4 times increased risk of hepatocellular carcinoma. For certain patients, a liver transplant is a modality of choice for those with end-stage liver disease, with a 5-year survival rate if the primary tumor is noted to be small. Radiofrequency ablation is indicated in those with small tumors. While extrahepatic metastasis is well documented, skull metastasis from hepatocellular carcinoma is considered to be rare, with a prevalence of approximately 6%. There are fewer than 10 case reports of patients presenting with similar presentations. Here we present an exceptionally rare occurrence of hepatocellular carcinoma metastasis to the right parietal skull 10 years after liver transplantations and 6 months following microwave ablation. Our patient was a 68-year-old male with a significant past medical history of cirrhosis related to alcohol and hepatitis C. He was on immunosuppressant therapy with tacrolimus and mycophenolate, with a microwave ablation 6 months prior to presenting to the emergency department due to a ground level fall. He also had reported a large lump on the right side of his scalp for 3 weeks with additional symptoms of forgetfulness, fragmentation, and dysarthria. Physical examination showed a very jaundiced patient with a noticeable mass on the right parietal region of his skull. Labs had shown an elevated transaminase as well as alpha-fetoprotein being 88. Reference range is 0 to 8, so significantly elevated. CT of the head showed a right parietal skull metastatic lesion. MRI of the brain confirmed this lesion, as well as an acute left parietal hemorrhagic stroke. Biopsy of this mass demonstrated metastatic carcinoma consistent with metastatic hepatocellular carcinoma. During the hospitalization, the patient had experienced several complications due to his multiple organ dysfunction, and the focus of management was stabilizing his multiple organ dysfunction and providing pain management. Unfortunately, despite medical interventions, the patient's organ failure progressed and he passed away 2 weeks after hospitalization. On arrival, patient's BUN and creatinine was noted to be elevated, but at time of passing, it had increased significantly. Same thing with his liver function and his transaminases. Figure 1 and Figure 2 shows the parietal lesion. Figure 3 and Figure 4 shows the immunohistochemical staining that confirmed the metastatic hepatocellular carcinoma. Hepatocellular carcinoma is one of the most common cancers found worldwide. Regions of the body where hepatocellular carcinoma often metastasizes to are the lungs, bone, lymph nodes, and adrenal glands. Prognosis for those diagnosed with this is very poor. What makes this case especially rare is the atypical presentation of skull metastasis from hepatocellular carcinoma after liver transplantation and microwave ablation. The average age of extrahepatic metastasis was reported to be 67 years old. Our patient was 68 years old. The outcome for those with this metastasis is very poor, and the median survival rate following the diagnosis of extrahepatic metastasis is close to 8 months. Unfortunately, our patient, the time frame was within 1 month, given the concomitant multiple organ failures. To our knowledge, there are few case reports describing a similar clinical scenario. From our knowledge, we are the first documented report of skull metastasis in a patient who had received a liver transplant and recent microwave ablation. Similar case reports include a few Japanese reports, one which included a 68-year-old male with a history of hepatitis C-associated cirrhosis and hepatocellular carcinoma with skull metastasis. A second report included a 56-year-old patient with skull metastasis from hepatocellular carcinoma in the setting of chronic hepatitis B. For this report, the patient was treated with radiation therapy and chemoembolization. He later decompensated and passed secondary to acute respiratory failure from pneumonia. By detailing this atypical presentation of skull metastasis from hepatocellular carcinoma, following microwave ablation and liver transplant 10 years prior, further research would be beneficial to establish the mean survival rate in those who undergo liver transplantation and microwave ablation post-diagnosis of hepatocellular carcinoma, and the factors that contribute to increased mortality in such patients. In addition, these patients may require increased surveillance for those who are diagnosed with hepatocellular carcinoma. Thank you for your time.